Today I'm going to talk about the effect of having Medicaid coverage earlier in your childhood on your later life use of healthcare services. And this is joint work with Laura Wary, Bob Kessner, and Bruce Meyer. And what really got us interested, oh, and I should say, I guess, before I launch off, is I would really welcome and love to have questions and comments throughout the talk, so please don't feel the need to wait till the end. Just raise your hand, and that would be great.
I'm sorry to interrupt. Is there some, can we turn the sound down a little bit? Some kind of a, I think there's some kind of a reverb or something on the sound. Is anybody else?
Can you hear it?
A little.
Yeah, okay, no problem. La 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 la. Okay, so our our interest in this topic has come from the fact that, you know, if you're in the health services research area, which I assume most of you are, you often hear discuss this idea that, oh yeah, there, I hear that reverb. You often hear discuss this idea that, well, it might be costly to bring kind of low-income, uninsured people into the system, give them health insurance coverage, give them access to care. That might have a big price tag up front, but if we can get their kind of chronic illnesses under control, if we can help them with disease management, if we can help them with healthy behaviors, we might be able to prevent more expensive care that they need down the line. And this sort of downstream cost savings could offset, or even sort of in a very optimistic world, maybe even partially or totally cover the initial cost of bringing these people in and getting them care in the first place. So you might hear anecdotes about, you know, for example, diabetes. You know, if you are able to get it, you know, managed under control, then you have sort of lower costs than if you end up in the hospital 10 years later after ignoring it. So it's these sort of this idea about cost offsets or downstream cost savings is something you hear a lot. But despite the fact that it's talked about a lot, we don't have great evidence as to whether these offsets exist, first of all, and how big are they? What is the extent? Do we save a lot of money or a little money? And I would say that one of the reasons that we have this limitation in the literature is that most of the research that we have, especially research that looks at public health insurance expansions, looks at things over a relatively short time period, right? So the Oregon Health Insurance Experiment, obviously an incredibly high-profile experiment where people applied for Medicaid and some were randomly put into the group that got it and some were randomly put into the control group, ultimately found no health outcomes or changes in most clinical health outcomes, but they only looked for about 18 months after the individuals had insurance. Now, if we think of health as a cumulative process, something that's sort of building up and building up over time, it might be that this, you know, 18-month, 2-year window to look at is simply too small to uncover these kind of health savings. Okay, so what we're doing in this paper is we're going to try to get around this challenge in the literature of these kind of short follow-up times by looking at an expansion that happened a while ago, that happened in the 80s and 90s, and to examine the impact of this expansion for low-income kids of the Medicaid program on their later life healthcare utilization. We're going to look at a discontinuity in eligibility that occurred for children born right around September 30th, 1983. So just very brief background, you know, Medicaid was initially linked to cash welfare, so only people that were receiving AFDC were Medicaid eligible. In the 80s and 90s, Congress began to sort of decouple these programs and expand eligibility to those who weren't previously eligible. Several of these laws that expanded Medicaid eligibility only applied to kids born after September 30th, 1983. So if you were born September 28th, 1983, which actually is my birthday, and if you were born in a low-income family, you experienced about 5 fewer years of Medicaid eligibility throughout your childhood than if you were born just a couple days later. Right? So in this study, what we're doing is we're looking at kids that were born sort of right before this cutoff and right after this cutoff and seeing how their use of care, now that they're young adults, is different. So what we find, we look at hospitalizations and emergency department visits, and if we look right when these eligibility changes happened, if we look sort of right following the period of Medicaid coverage, we actually don't find any difference in use of hospitalizations for those born right before or right after the cutoff. But when we do a 10-year follow-up and look at these cohorts when they're 25 years old, we find that black patients in particular had fewer hospitalizations and emergency department visits, and in particular had fewer hospitalizations and emergency department visits for visits that are classified as chronic illnesses, as needing sort of ongoing intervention. These effects are particularly pronounced for black patients living in low-income areas. And we use a little bit of cross-state heterogeneity and find some suggestive evidence. You'll see it's a little bit weaker, that the effects are largest in states where this discontinuity in eligibility at the cutoff is greater. So our results imply, if we sort of take some kind of conservative assumptions, we assume that these results are only present in the year that we observed them, which is 2009. This implies that between 3 and 5% of the initial cost of providing the Medicaid eligibility in childhood was offset by this lower rates of utilization later in life. Now, obviously, if you want to assume that these results are going to last for 10 years, then this would be 30 to 50%. But if we just look at 1 year, we see a 3 to 5% offset in costs. Okay. So let me give you some background. So this paper is part of an emerging literature, a pretty recent but sort of quickly growing area of scholarship that looks at the longer term effects of Medicaid coverage. So there have been papers that have found that having Medicaid coverage in childhood results in better test scores for children, higher rates of high school and college completion, as well as a lower incidence of chronic conditions among adults, and also lower earned income tax payments and higher tax receipts for the government and lower mortality rates. I have another paper with some of my co-authors that look at the prenatal expansion specifically and find actually large effects for these very early life Medicaid coverage expansions on adult outcomes as well. However, despite the fact that this is kind of a really robust and growing literature, I think one thing that this paper can contribute to this discussion is that we're looking at this discontinuity in coverage rather than looking at state-by-state changes. So these other papers that I've listed here, with the exception of Wary and Meyer, which uses the same research design we're using here, basically they look at a state that expands Medicaid, a state that doesn't expand Medicaid in different years, and makes these kind of state-by-state comparisons. Obviously, this is potentially, at least, you might worry about other concurrent changes in state policies. So we think looking at this through the lens of this discontinuity in eligibility could potentially, be a stronger research design and provide some evidence to sort of bolster these existing papers. Okay, so a little bit of background. So starting in 1984, Congress began to expand Medicaid eligibility for children who would not have received Medicaid eligibility if they weren't in AFDC eligible households. And this began sort of a series of expansions that occurred at the federal level. And many of these were specifically applied to children born after September 30th, 1983. And this is a discontinuity that's been used to look at take-up by Card and Short Shepherd in 2004, as well as teenage mortality by my co-authors Wary and Meyer. So these are the 3 Medicaid expansion laws that we're using to get some leverage with this discontinuity. The first is the DEFRA 1984, which said children under the age of 5, if they're in AFDC income-eligible households, if they're born after September 30th, 1983, need to be eligible for Medicaid. Right? So it's a mandatory expansion. Then in 1987, there was an expansion that was optional that states could take up, in which they said, okay, if you're under age 8, right, and you're born after September 30th, 1983 in an AFDC income eligible household, you'll be Medicaid eligible if your state decides to take up this policy. Right? And then the final policy, OBRA 1990, which most of our variation, most of our bite is coming from this, said all children 18 and under, if you're living in a household with under 100% of the federal poverty level as your income, if you're born after September 30th, 1983, you will have Medicaid eligibility. So naturally, these laws that only applied to people born after a certain birth date created a lot of variation around that birth date in the number of years that a child could expect to be eligible for Medicaid throughout their childhood. So this graph, on the y-axis, I've plotted the average number of years that a child would be eligible for Medicaid between 0 and 18 years old. Right? And on the x-axis, I have put different birth cohorts. So if you were born in October 1979, this describes how much Medicaid eligibility you'd have throughout childhood. Okay? And the different lines represent different family incomes. And I know this might be a little bit hard to read. So up here, these are for children in households that are very poor, under 25% federal poverty level. And what you can see is that for all birth cohorts, Medicaid eligibility is quite high because most of these kids are in AFDC eligible households, right? So they basically already had Medicaid without these laws. Similarly, if you look at these people in still quite poor households, but above the federal poverty level, between 125 and 50% of the federal poverty level, again, it's pretty smooth. There's no real discontinuity at the birth date because the laws that were surrounding this birth date applied to children in poor households. But if you look at, for example, a child that was born in 1979, 1980, all the way up through September 1983, in a household that made between 75 and 99% of the federal poverty level, you can see that just the difference between being born in September versus being born in October makes a really big difference in the number of years that you can expect to be Medicaid eligible throughout your childhood. About 5 additional years being born in September versus October. And we might think that otherwise, being born in September or October, it doesn't change your eligibility for other social programs, and there isn't really a strong reason to think that it would affect your health outcomes in other ways. But one thing that is really affected by this birth date is how much eligibility you might expect to have throughout your childhood. Right? And so we're going to use the folks that were born, essentially in September, as a comparison group to the folks that were born in October in a natural experiment setting. Okay. So this figure shows a few interesting things about this policy. So on the y-axis here, I have the share of the birth cohort that is Medicaid eligible. And on the x-axis, I have their age in years. The solid line is for people that were born in October 1983, and the dotted line is people that were born in September 1983. So the goal of this figure is to show you what ages were these children when they were gaining this extra Medicaid eligibility. And what you can see, which is interesting, is it's really between the ages of 8 and 14 that this extra eligibility was experienced by children that were born in September versus October. Another thing that you can see that is interesting is that if you compare non-black children to black children, you see a much bigger effect of these eligibility changes on black children than non-black children. And that's due primarily to the income distribution of children in black houses versus non-black. Right. So it's this discontinuity we're going to use to study later life hospitalization and emergency department visits. Okay, so this essentially gives you the same information, but in a table form. You can see that, if you look overall, about 10% of people, children, gained eligibility at this threshold. And among those that gained eligibility, they got an average of 4.5 years of additional Medicaid eligibility by being born across the threshold. And that this effect is bigger for black children than for non-black children. So about 17.25% of black children would have gained eligibility by being born in October instead of September, and gained about a little bit under 5 years versus 8.7% for non-blacks, who gained about 4.4 years of eligibility throughout childhood. Okay. So this is our main research design. Are there any questions so far on our approach? No? Great. Okay, I'll talk about the data in that case. All right, so the data that we're using, we've sort of cobbled together data from a few different sources. Our main source is the Healthcare Cost and Utilization Project, which has a census of all emergency department visits for a set of states, and also for inpatient hospitalization. So these are every single emergency department visit that happens in the states that participate in the database, as well as every single hospitalization that happens in these states. So we have 100% coverage, but only for a subset of states that participate in this data repository. In addition to the HCUP data, we also have inpatient and outpatient data from California and Texas. So, all right, so for emergency departments, we only observe emergency department use in 2009. That's when these relevant cohorts are 25 years old. And we have emergency department visits for Arizona, New York, Iowa. Okay, like I don't have to like read the whole list to you, but we have a bunch of states here that we have the emergency department data for. For the inpatient data, we observe them at two different periods of time. We see them in 1999. This is when the relevant cohorts are 15 years old. And if you remember that figure I just put up, this is right after the period they get Medicaid. So you can think of this as this sort of short-term effect, right? So in 1999, we have data on Arizona, California, New York, this list of states here. In 2009, by 2009, more states had begun participating in this data repository. And so we're able to add this list of states here. So why did we choose these states is a question I often get asked. We didn't choose them because we like these states. These happen to be the states that collect this data and collect and provide information on date of birth, which is of the patient, which is obviously very important if we're going to look at changes that happen around a birth date, right? To our knowledge, these are all of the states that are available for us to use. But if you know of other state inpatient databases we could add, I would love to hear that. Yes, please.
Do you have the location of birth or just the date of birth?
Just the date of birth.
So then your analytical strategy, it's not treatment on the treated baby, it's just an average.
That's right. So the fact that we don't have state of birth, so a couple things I'd like to respond. That's a really good question. First of all, what we really would like to know is like where were you living between the ages of 8 and 14, and how much money did your parents make at that time? With that information, we could really nail down who was affected and who was not, and do a treatment on the treated. We don't have that information. All we know is when were you born, and what state are you living in right now, right? And so we're going to have to assume that for most people, the state that they're living in at age 15 or age 25 is the state they were living in when they were 14. That's probably not a great assumption because people go to college like when they're 25 or they move away for a job or what have you, right? So the extent to which we're not doing a good job nailing down the state they lived in childhood should in general make our estimates smaller because we've introduced some mismeasurement. Now we've looked in the National Health Interview Survey data and we've looked at the American Community Survey data, both of which have both your state of residence and your state of birth. And we haven't found that there's any correlation between moving out of your state of birth and being born right after the threshold. So it doesn't seem like people born right after the threshold are more likely to move away, which could be a bigger problem, we think. In general, we think this is probably just going to make our measures noisier for that reason. Harold?
One thing, I was thinking which states you have and don't have any, you don't really have any states in the Deep South.
That's right.
So some of the African Americans who might have the biggest chunks
Yeah.
just won't be visible in this.
That's right. That is an unfortunate feature of this data is that a lot of the states in the Deep South just don't collect this administrative data. And so it's not available for us to look at. To the extent that That's right.
So I would think the states in the Deep South would be among the least likely to do the expansion.
It's actually the opposite because these were mandatory expansions. So the states where this has the biggest bite are states that were relatively cheap beforehand. So you can see we have California in our data. California sort of kind of took it upon themselves to cover all these kids even before it became mandatory. And so we have very little discontinuity in California. Whereas Maryland, for example, we have a larger discontinuity because they hadn't kind of taken up optional expansions to cover these kids anyway, and so when the federal mandatory expansion came in, it really made a big difference.
Were all of them mandatory, or was it some of them? I thought some of them were if your state chose.
Let me go back. So the 1987 was an optional expansion. But I would say most of the biggest impact on this discontinuity is coming from the 1990 expansion, which is saying through age 18 in all households under the federal poverty level, it's mandatory to provide children with Medicaid eligibility if they're born after the birth date. And so because this was mandatory, states that had sort of opted previously to not be very generous kind of experienced the biggest bite from this law. Yeah, that's a good point. Yeah.
Back in the early and mid-'80s years, and I'm not sure how these numbers apply to kids on Medicaid as opposed to Medicaid overall, but the monthly turnover of Medicaid membership was something on the order of 5%.
Mm-hmm.
So from month to month, 95% of the people were eligible the month before remained eligible, and some dropped off and new ones came in. And which means that over a period of a year, the number of people with any Medicaid coverage was much larger than the number of people with coverage at any given point in time.
Mm-hmm.
And if I understand correctly, you don't have the ability here to know anything about the individual continuity of eligibility for the kids who you're looking at. So how does that affect your possible results?
That's right. So that's correct understanding of what we're going to do. So we've looked back. The figures that I put up are just an average fraction that are eligible. Obviously, if you are in a low-income household and your household remains low-income throughout your entire childhood, it's a much bigger effect than if you're in a low-income household, then next year you're above the federal poverty level, maybe for a couple years, then you're below, and so your eligibility or your enrollment kind of bounces around. So to the extent that that's going on, which it almost certainly is, we're going to be just looking at the average effect. I mean, essentially what we're doing is we're looking at the average effect of being born on one side of the threshold versus the other. So if on average you got one additional year, then that's the effect that we're capturing. So if you had like a long administrative panel where you knew people's enrollment and then you could link that to their later life, you could separate out, okay, these are the people that were enrolled a really long time. We would expect them to have a much bigger effect than people that were only enrolled a month. But unfortunately, in our data, we don't have an ability to do that. So the effects that we find are almost certainly covering up some pretty big heterogeneity. Probably some people had no effect at all. Some people had a huge effect, and we're getting some kind of local average here. Good questions. Great. Okay. So these are the states that we're using. We're going to be covering about 50% of all hospitalizations in 2009 that occur in the U.S. In terms of population, about 35% of all ED visits. So these are, really big data sets, which is important because we're looking at people when they're still relatively young, and so their utilization rates are pretty low. So we want to have enough data to detect this. At the same time, it's definitely, as Harold pointed out, not representative. So we're missing the Deep South in particular is not well represented. Okay, so some descriptive statistics from our data. These are hospitalization rates per 10,000 individuals and that have occurred in 1999 for 15-year-olds. This is the age that sort of cutoff cohort is in 1999. And what you can see is there are about 260 visits per 10,000 individuals for all races, but quite a bit more for blacks than for non-blacks, 323 per 10,000 individuals for blacks and 253 for non-blacks. We look at visits divided by chronic illness status because we're thinking about long-term effects, and so we think, I think quite sensibly, that something that's chronic, that's ongoing, is more likely to be affected. And 1999, there's about 137 chronic illness hospitalizations per 10,000 individuals, and 193 for black patients and 131 for non-black patients. In 2009, looking at 25-year-olds, the first thing that you notice when you look at the descriptive statistics is that hospitalization rates have gone up. So now hospitalization rates are 329 per 10,000 individuals. And then if you look at emergency department visit rates, they're about 10 times more common than a hospitalization. And they tend to be for less serious conditions. So emergency department visits, there's 3,167 per 10,000 people for 25-year-olds. Right. Another thing you note about emergency department visits is they tend to be for acute conditions and not for chronic conditions. And then again, you also see these racial disparities in hospitalizations, especially for chronic illness visits, about 2.5 times the rate among black 25-year-olds than non-black. So before we start looking at the long-term effects of Medicaid eligibility on hospitalizations, we first want to kind of get a sense of, did this actually do something with enrollment, right? Did people actually sign up? We don't have kind of great comprehensive administrative data on enrollment, but we do have the National Health Interview Survey from 1992 to 1996, where we can at least see if people were reporting in the survey that they were more likely to be enrolled in Medicaid. So our framework to actually arrive at these estimates, I'm going to show you the results from a few different local linear models, as well as some more parametric second-order polynomial models. We're going to include calendar month of birth fixed effects just to reduce the noise a little bit. For hospitalizations and emergency department visits, the dependent variable is in log, so you can interpret the coefficients as percents. Great, okay. So this is first for the entire sample. Let me explain this figure a little bit more probably than needed in detail, but like literally the rest of this talk is just this figure like over and over again. So I really want to make sure people understand how I've set things up here. So 0 is October 1983. This is the first month where you get Medicaid eligibility based on these birth date cutoff rules. And then going this way, this is like, so here's October, here's September, here's August. Going backwards in time this way and forwards in time this way, these people are older and these people are younger. Right? So part of the trends that we're going to be picking up are age trends. And what our model assumes is that with our trends or with our local linear regression, we can kind of fully account for the age trends. And so any break that we would see would be attributable to the policy. So here, you might think you would see, dot, 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 and then some kind of big jump, and then dot, 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 up here. Right? We don't really see a big break in this figure that I've just put up, which maybe wouldn't surprise you since we're looking at the entire sample, and I told you earlier that only about 1 in 10 people were affected by this policy. So it's not surprising that there would be kind of a smaller jump up here, or no jump actually up at all. On the bottom, I've put the actual kind of numbers that come out from the model, and you can see it looks like maybe a 1 percentage point change in eligibility, but not statistically significant. Okay. When we look just at black respondents, it's quite a bit noisier, so we have a much smaller sample in NHIS when we just segment on race, but we do see a statistically significant increase in the fraction that are reporting that they have Medicaid coverage of between 5 and 7 percentage points. This would be consistent with about a 35% take-up rate, which is definitely in the range in the literature. When we look at all other households, we don't find anything. Actually, it's quite smooth across the cutoff. This was kind of somewhat surprising to us, but this is what we see in the data. And finally, when we try to just zoom in on households that are under the federal poverty level, since we know that these are households that the policy targeted, we see a bigger discontinuity in Medicaid enrollment. Right? So we see between 6 and a 9 percentage point increase in Medicaid enrollment at this cutoff birth date. Okay. households over the federal poverty level, we don't find any statistically significant effects, which again is consistent with how the policy was written. Okay, so we start by looking at 1999, when these cohorts were 15 years old. And this is the time period that sort of immediately follows this additional Medicaid coverage, right? So you can think of these as sort of a little bit shorter term effects on hospitalizations. But also keep in mind that there's lower rates of hospital utilization in general at age 15. And so perhaps there's maybe less of a scope for hospital rates to come down. And we don't find really much evidence of any change at the threshold looking at the 15-year-olds. Right? So this is for black patients, this is for non-black patients. In both cases, we don't find that there's any decrease in hospitalizations. So we also look at this for chronic illnesses versus non-chronic illnesses, and we don't find, on either subgroup, we don't find any effect. So if we had kind of stopped our analysis here and said, well, looks like there's just no offsets for Medicaid, then this would be the conclusion that we would draw. However, we did want to look at the longer term, and I should stress that we did not look at the shorter term and then say, well, let's look at the longer term. This was part of the research design from the beginning. The next thing we do is we look at the longer term effects. That's a 10-year follow-up looking at 2009. So a few things about looking at this time period. The patients are a little bit older. They're 25. Their rates of hospitalizations are a little bit higher. And there's also been more time for any sort of healthy behaviors or disease management type of behaviors to manifest. Okay, so looking at black patients, now when we look at hospitalizations overall, we do find a decrease in hospitalizations at the cutoff of between 7 and 14%. When we look at non-black patients, we don't find any evidence of such a decrease. Right, so this is consistent with what we saw in the first stage, or in the National Health Interview Survey data, where we didn't see any take-up, and we also don't seem to see any later life effect. Right? So between 7 and 13%, that seems actually kind of like a really big reduction to me in hospitalizations. But what does that translate in terms of actual hospitalizations avoided? Well, given the initial baseline rates that I showed you, this means that there would be about 43 fewer hospitalizations per 10,000 people in the population. So if you remember that about 17% of black children would have gained eligibility across the threshold, this means that there would be about 0.025 fewer visits for everyone that gained eligibility, or put differently, for every 100 people that got eligibility, there was about 2.5 fewer hospitalizations in young adulthood. Right. So this is actually pretty big relative to the sample mean, but you should bear in mind that we know there's a very strong income gradient in health, and so the mean among the group that was gaining the eligibility is probably higher. Okay. So next we look at the cause of the visit, whether it's for a chronic or an acute condition. Because we're looking over a long time period, we think, I think sensibly, that chronic conditions are more likely to be affected because they're present over a long time. And we're using the HCUP classification software to determine what is chronic and what is acute. So we find for chronic illness hospitalizations between an 11 and a 17% reduction for those cohorts born right after the threshold among black patients. But even for chronic conditions, we don't find any evidence of a similar reduction for non-black patients, and in fact, disturbingly and sort of marginally significant in some models, maybe even a little bit higher chronic illness utilization. Right. When we look at black patients at their non-chronic illness hospitalizations, we actually don't find as much. We find some smaller reductions, but they're not consistently statistically significant. So this really does look like a story that is being driven by these chronic type of conditions that are present in over a long period of time. Okay, and then again, sound like a bit of an old hat here, but again, it really only seems to be showing up when we're looking at black patients. Okay. So the next thing we do is we look at emergency department visits at age 25. We'd like to be able to do this at age 15, but the data just don't exist in 1999. So these are emergency department visits are times when you show up at the hospital and you aren't admitted. So if you went to the emergency department, you ended up being admitted to the hospital and staying overnight, you would have been in the hospitalizations database I just showed you. These are just visits where you show up, you get treated, and then you leave the same day that you get treatment. Right? So they tend to be for less serious conditions. They're also much more common. They're about 10 times more common than hospitalizations. Okay, so here we see, so here's emergency department visits for Black patients. And here we see, a little bit of a reduction possibly, but it's not really consistently statistically significant, but at least somewhat, suggestive that there might have been a smaller reduction in emergency department visits here as well. And we don't find such an effect for non-Black patients. When we look just for chronic conditions, again, we're seeing a little bit of a reduction. This is quite noisy because if you recall the table I put up towards the beginning, relatively few emergency department visits are for chronic conditions. They tend to be for acute conditions. But it does at least look suggestive that there is some reduction, although you can see the polynomial is kind of doing a lot of work here. Okay. For non-Black patients, it's really quite smooth across the threshold. Great. Okay. So basically, we find for Black patients some suggestive evidence of fewer emergency department visits for those born right after the threshold, and we continue to not find effects for non-Black patients. So we've looked at heterogeneity by the type of visit, chronic or non-chronic. The next thing we want to look at is heterogeneity by where the patient is coming from. So we're using these hospital emergency department databases that are great and are incredibly rich if you want to know about that hospital visit. They have all the procedures, they have all the diagnoses. You can learn a lot. They don't really have the sort of rich demographic data that you might get from a survey like the PSID, or they certainly don't have any information on family income. And so looking through our hospital databases, we're trying to locate some variables that might tell us who was in a group that was more likely to be affected by these policies. So in 2009, we have information on the median income of the patient's zip code where they live. Right? So if children who grew up in poor families are more likely to reside in low-income zip codes, we might expect larger changes in hospitalization rates for patients that are from these zip codes. Right? So that's the next thing that we look at. And that's actually what we find. So here we're looking at Black patients that are from low-income zip codes, and we find a 10 to 23% reduction in hospitalizations among patients from these zip codes. Here is the same figure, but for chronic illness hospitalizations, and these are really quite a bit larger, 15 to 28% reduction in chronic illness-related hospitalizations when we just look at the low-income zip code sample. So if you recall what we got before, so we saw a 7 to 14% reduction overall for utilization of hospitals for Black patients. In the low-income zip codes, it's 17 to 23%, so quite a bit bigger. 11 to 17% reduction for Blacks overall, 15 to 28% when we just looked at the low-income zip codes when we looked at chronic illnesses. We don't find a statistically significant effect on non-chronic illness visits, as we saw before, and we also continue not to find an effect on other races. Okay. For emergency department visits, we have kind of a similar looking figure that we had originally, where we see kind of some small, but in a couple models, statistically significant reductions in emergency department visits, but it's not a sort of, it's nowhere near as large, and it's not kind of consistently showing up in our regression estimates. Okay. But if we just take the point estimates seriously when we compare them, it does look like the point estimates are bigger for the low-income sample than for the non-low-income sample. Okay. So are there any questions so far about the approach? Yeah, yeah.
Just trying to think about exploiting the zip code data a little bit more.
Mm-hmm.
If you have hospitals that are in border counties, and those border counties, like state border counties,
Mm-hmm.
and there's some concern that we know that low-income populations are very mobile, and you're in a border county, and the next state over is passing this great law for kids, and you think, heck, why don't you just pick up and move over? Is there any benefit to using the zip codes with hospitals to kind of proxy for whether you were picking up these people that might have migrated? Is there any way to use that information? Or maybe you're going to need the zip codes, just having border county identifiers might be enough to see if there was, because that would have worked to increase the effect, wouldn't it? You had people selectively migrating into a state that had a policy change.
So here we're not using any state level variation. So if they move to another state that's in our data set, then they're still, as long as they don't change their birth date, it's not an issue. In a few slides, I'm going to show you some results that compare states that had a big effect versus states that had a small effect. In that situation, that could be a problem, because there we are using some state level variation in the policy.
I guess what I'm saying is that I'm not saying that your identification is incorrect. You're still identifying based on birth date, but your actual treatment estimate is including people selectively migrating to a state because of the policy change. And so the sample represents two things. It would represent the policy change and also a migration effect.
So you're saying if people migrated in response to the policy and that also has some effect on their later life health, like maybe migrants are less healthy.
A different kind of person would be motivated to move versus
So I think the bigger concern for this model that I've been showing you is if they were to migrate to a state that's out of the sample. So if they migrate between states that are in the sample, then they're still going to show up in the data, whether or not they're on one side of the birth cohort cutoff or another. Now, if they were to migrate out of the sample, there might just be fewer people after the cutoff to have hospitalizations, and that would look like a reduction in hospitalizations.
So empirically, that I would say that would be bad, but theoretically, I don't think that people would want to leave the state where they have generous social policies.
So these aren't the states that have generous social policies. These are just the states that have data that are in my sample.
Oh, that's right. That's right. So you've got states that do both.
Yeah, so some of the states have generous social policies and some don't. So we were actually really concerned about that because we only see some states and we only see states that have good administrative data, and maybe states that have good administrative data are attractive on or unattractive on other dimensions. Again, I didn't, maybe I should have put this in the slides, but we did look in a couple data sets where we could see both state of birth and current state of residence. So the American Community Survey has that, for example, and National Health Interview Survey has that, and they also both have birth date. So we tried to see if there was sort of a migration effect at the cutoff, and we didn't find any evidence of that. So we were reassured at least by that, I would say. Okay, so thanks for the question. So one kind of comment I've gotten before and discussing with my co-authors is, okay, that's really interesting. It looks like chronic illness-related diseases are going down, at least hospitalizations for them. But what does that really mean? Like, what is driving this? right? I mean, what's the actual story? I mean, chronic illness is a really big category, and it comprises a lot of different diseases. Is this things that are treated by medication, or can we find more evidence of mechanisms? So the next thing that we do is we try to drill down a little bit more. Now in this set of results, we're kind of asking a lot of the data, because we're going to try to drill visits down into these categories that are defined by the International Classification of Diseases of different types of diseases. Since utilization rates are pretty low, you'll see some of these diseases have pretty sparse population in their cells, and so they're a little bit noisier, but we're hoping that this could shed a little bit of light on what's really going on kind of under the surface here. Right? So let me start. There's a bunch of different disease categories. Here I have I don't have all the figures for you because that would just be like way too much, but I have the point estimates for different polynomial models and local linear regression models. Here this tells you how many per 10,000 people, how many visits for this age group are there. So infectious and parasitic diseases, this is just among blacks. This is, there's a high rate of HIV in this category, but also other infectious diseases are in there as well. The percent of the category that's classified as chronic is about 25%. And this category represents about 1.8% of all chronic illness hospitalizations for this group. So that's just to try to give you a sense of what is driving these results, right? What type of visits are going down? So we find kind of pretty consistent evidence that there's a reduction in infectious and parasitic diseases. Neoplasms, this is basically tumors, really, really low utilization rate, so we can't really say much, but it doesn't appear to be affected. Endocrine, nutritional, metabolic diseases, and immunity disorders, this is almost all diabetes for this age group, and we see pretty big reductions in diabetes here. And this category is also almost all chronic illness, considered chronic illnesses. So diseases of blood-forming organs, this is mostly sickle cell anemia. We see kind of consistent negative point estimates here that these could be going down, but they're not statistically significant. Mental disorders actually, surprisingly, is a very big percentage of hospitalizations for this age group, and we sort of thought maybe mental disorders would be like, I'm going to be honest, we were kind of looking for like a real nail in the coffin that we could say like it's just diabetes or it's just mental disorders, but we actually are finding pretty broad effects. And actually we don't find very much going on for mental disorders. Consistently looks like a negative effect, but not statistically significant. Diseases of the circulatory system, we're finding some negative effects here, but not, it's a little bit on the noisy side. Diseases of the respiratory system, this is acute bronchitis and asthma mostly make up this category for this age group. For most models we find some pretty negative effects, but again, still a little noisy. Diseases of the digestive system, this is like Crohn's and some other digestive system diseases. We find some, in the local linear regression model, we find some strong effects, but yeah, a little noisy, like I said. Diseases of the genitourinary system, not really any kind of consistent statistically significant effects. Skin and subcutaneous tissue, we don't really find much. Diseases of the musculoskeletal system and connective tissues, we find a lot of effects. This is interesting. This is mostly back pain, which you would be surprised. I wouldn't have thought that would be something we would find something on, but you also have to bear in mind it's very low incidence, so kind of a small number of people have it, but it seems to be going down. And then symptoms, signs, ill-defined conditions, it basically means we don't know what's going on with you. Not really seeing much there. Yikes. Great. So as I said, we were kind of sort of hoping to have a nice clean little story to wrap it up, like, oh, it's all asthma, it's all diabetes, but instead what it really looks like is broad-based improvements that are kind of affecting a lot of different categories. Kind of across the board, and there are a few that kind of stick out. Diabetes kind of sticks out. Parasitic diseases stick out. Yeah.
Word improvements there.
Mm-hmm.
exactly sure how to draw the map between people got hospitalized less and there's an improvement. Is there, I mean, is there some, I mean, it seems like it could be other kinds of stories, like when Medicaid dominates healthcare for low-income African Americans, that the care practices of Medicaid providers are less hospital intensive, or it seems like there's got to, how do you, that word improvement, unpack why, other than the coefficient, why you think there's an improvement.
That's a good point. So we're kind of limited here in that we're only seeing a slice of the total healthcare pie, right? So that's, it could be that they're having fewer hospitalizations, but they're having more of something else. And if that more of something else is bigger than the decrease in hospitalizations, then that, even from just a pure cynical cost perspective, that might not be an improvement. But at least for some of these categories, it's considered, so for example, HCUP considers all diabetes-related hospitalizations to be unnecessary and resulting from a failure of preventive care. Like they're all preventable, basically. So any kind of reduction that we see in this category, I think most health services researchers types would tell you is indicative of a general improvement in the quality of care for diabetics. Because these diseases are so broad and they're all treated differently, nervous system diseases, this is mostly epilepsy, this is mostly treated with drugs, so maybe this is a story about finding a better fit with your epilepsy drug. But I can go through and I can kind of make up little stories like that for every category, but because they're so diverse, I don't think for every single one I can tell you for sure, oh, there's no kind of offsetting increase in cost somewhere else in the health system. The second thing I would say about that is that hospitalizations are for quite serious events, and they aren't, emergency department visits, a lot of times you can make the case that this is something that could be treated in a doctor's office, but if you're staying overnight at the hospital, it indicates, in general, a fairly serious health event. And so I think there aren't as many potential substitutes for hospital care as there are for other types of care. And it's very costly, and it's very expensive. So. Okay. All right. So the next thing I'll talk about just briefly. Let me check my time. Is looking at using some of this variation from state to state in the size of the discontinuity to see if we have a bigger effect in states that had kind of a bigger bite from this law. The largest discontinuity in our data set is in Arkansas, where there was kind of a large gain, even unconditional on being one of the people made eligible across the threshold. There was kind of a large gain in eligibility. The smallest discontinuity was California, where they had largely already expanded Medicaid eligibility prior to these mandatory laws, and so there wasn't much of a discontinuity. So we might expect to see larger effects where the discontinuity is larger, although there could also possibly be some heterogeneous effects due to state characteristics. For example, if in Arkansas they were relatively ungenerous before 1990, maybe even after 1990 they make it difficult to sign up, right? Maybe they do checks for your eligibility repeatedly to try to keep you off of the Medicaid rolls, for example. So just keep that in mind as we're looking at the cross-state variation. So to operationalize this, we use a model that looks at cohort by state level utilization. We have a state fixed effect, a calendar month of birth fixed effect, and then our main coefficient of interest is going to be, so here's the indicator that you're born after this birth date, and here we've interacted this indicator with the size of the discontinuity in your state, right? So beta 2 captures this idea of if your discontinuity was bigger, how much bigger is the effect of being born across the threshold. Okay. And then, you know, we have a small number of states, and so we do some stuff with standard errors to try to account for that. Okay, so I'll first show you the estimates of the first stage. This is from the National Health Interview Survey using state level variation, and it does look like now we actually do see, when we exploit this variation, some increase in Medicaid eligibility or Medicaid enrollment for other race groups. But it does seem to be the case that states with a larger discontinuity, there was also larger signups for Medicaid across the threshold. Right? I'm sorry, I know these are a little bit small, but we, when we do this interaction model, we see now more evidence for effects with all races of a reduction of between 6 and 10%. We estimate a few different types of models to kind of show robustness, and it doesn't seem to be terribly robust to estimating it in a different way. But at least it's kind of some suggestive evidence that as the state discontinuity gets bigger, the effect of being born across that threshold gets bigger on hospitalizations. Right. And we do seem to see some effects for other races. And interestingly enough, we find about the same size effects for black patients as we do when we look at all the states pooled together. But the confidence intervals are pretty wide. Part of the reason for that is that for some of these states, there's just not a very big black population. And so when we try to figure out what the discontinuity was just for that population, it's sort of estimated in a noisy way. So there are some technical reasons why we might expect there to be more noise in these state-level regressions. Okay. For emergency department visits, we see kind of roughly the same story, where the point estimates at least all seem to indicate that there were fewer emergency department visits across the threshold in states with the bigger discontinuity. But again, tend to be a bit noisy and don't seem to be, you know, although we always are seeing negative effects, they don't seem to be kind of very robust to changing the model too much in terms of statistical significance. So, you know, we think of these as, you know, suggestive evidence that there is this state-level heterogeneity that's coming from the size of the discontinuity. The interaction term is generally not statistically significant, at least in all of the models, but it definitely indicates that the high-gain states, you know, if you look at the point estimate, were experiencing bigger reductions than the low-gain states. Okay. So finally, before kind of going on to some back-of-the-envelope cost estimates, I just want to talk to you a little bit about some placebo tests that we've done. You know, we're doing these models, and we see some discontinuities, but the data, of course, are a bit noisy. We don't have all states, and so we want to really make sure that we're not over-interpreting things. So we do a couple placebo tests. The first, we look at the discontinuity on sort of acute conditions that we thought were probably unlikely to be affected by care in childhood. So appendicitis and injuries, it's like traumatic injuries. We think these maybe you can tell a story where they would be affected by having health care when you were a child, but it certainly just seems more distant than something like epilepsy or diabetes. Right? So we don't really expect to find an effect there. And then the other thing we do is we estimate a bunch of, you know, regression discontinuity models at cutoff dates where there actually wasn't any change in Medicaid eligibility. So we pretend that June 1st, you know, 1980 was actually like the cutoff date instead of September 30th, 1983. Right? And actually, we do this for every possible fake cutoff date, starting in January 1965, going up to the true cutoff date. And that gives us a distribution of placebo effects that we can compare our main effect to. Okay? So first, the appendicitis and injury results. Basically, we look at injury and appendicitis. We look at all these different ways of estimating the regression discontinuity design effect, and we find no statistically significant effects. Now, the confidence intervals are a little bit large, but we really take comfort in the fact that the point estimates we're getting even are very small. So we were seeing, you know, a 23% reduction in chronic illnesses, chronic illness-related hospitalizations. Here, if we look at, injury or appendicitis, we see something like, a 1.4% reduction, right? For the most part. Right? This is for the low-income group. These placebo effects, again, with all these different models that we've done, all these different groups, we don't find even a single statistically significant placebo effect when we look at appendicitis and injury. So this is the other placebo test that we do, where we look at the fake cutoff points where there wasn't a real discontinuity. I've plotted all of the coefficients that we get. So we do 129 placebo tests, and I've plotted the histogram of them. And then this dark line is the true effect that we get at the real cutoff point. So this is for all hospitalizations in 2009. We find that if we use this placebo distribution, it's significant at about the 10% level. So about 10% of placebo effects are larger in magnitude than the true effect. When we look at the local linear regression model, here we only see 1%. I think actually only one placebo test is larger in magnitude than the true effect. When we look at chronic illnesses for 2009, using the parametric model, we see 5.4% of placebo effects are larger in size. And Gesundheit. And when we look at the local linear regression model, we see only about 3% are. Right, so this, we think, pretty strongly confirms those results from 2009. We look at the low-income group. We see about 3.8% of placebo effects are bigger. And when we look at the local model for the low-income group, our true effect is bigger than every placebo effect that we do. This is also true when we look at chronic illnesses for the polynomial model and for the local model. So I think this is really strong evidence that if you, compared to any sort of fake cutoff where you might estimate a treatment effect, the true effect is really quite a bit larger. Okay. We don't have the same sort of success with the emergency department visits, where we do find kind of a lot of placebo tests that are larger. And if you remember when I was showing you those results, those didn't tend to be kind of consistently statistically significant, and they also tend to be quite a bit smaller. So we think that that's consistent with what we were showing you. So here's the chronic illness ones. About 9% of placebo effects are larger. And that looks the same when we look at the low-income group, too. So I won't drag you through all of that. OK. So the last thing I want to talk to you about, so I sort of motivated this talk by saying, oh, well, we're going to spend this money up front, and then maybe we save some money later. So I hope that I've shown you that it does look like there are some savings. I mean, as Harold pointed out, we don't see every single type of care that they use. But looking at hospital and emergency department care, which is a really big chunk of spending, it does look like there are fewer hospitalizations. We look at how that translates into costs we use this cost-to-charge ratio. So we see how much the hospital has charged for these visits. Of course, they can kind of charge whatever they want. That doesn't mean the insurance company is going to pay for it. There's this ratio that's used by CMS to sort of turn charges into reflect the hospital's resource costs. So we know that's an imperfect measure, but we use that as kind of a proxy for how much do these hospital visits cost. Okay? And then we make that the dependent variable. And as you can see, as you would have expected from what I showed you with the hospital results, we see significant reductions in costs for Black patients and not for the other race groups. So what does this mean in terms of money saved? It suggests that there is between 8 and 14% lower hospital costs due to these expansions. So the total cost in 2009 for the cohort born 1 year before the cutoff was $231.6 million. So these point estimates suggest that eligibility expansions reduced hospital costs for Black cohorts by between $18.5 and $32.4 million. And then you can do the same calculation using the emergency department visits, and that suggests a cost offset of between $6.7 and $10.6 million for the emergency department visits. So in bringing the cost of the eligibility expansions up into $2009 using a 3% discount rate, those expansions cost $910 million in 2009 dollars. Again, inflated with a discount rate. Yeah.
About the cost for, let's say the hospital can save 10% of their cost in the next 10 years, but that does not necessarily mean Medicaid saving a certain amount of money, right?
That's right. That's absolutely right. So maybe the hospital costs have gone down by, this amount, but that would have just been uncompensated care, right? So maybe the hospital is saving that money. Or maybe that would have been care that the patient would have paid for out of pocket, so maybe the patient is saving that money. So I'll show you in a few slides, we look at who's the payer. And we actually do find that a good bit of it seems to be going back to the government, in the sense that there are fewer Medicaid payments made for these people born right after this cutoff. That's a good point, though. So if we just look at 2009, and again, just stressing we only have data from 2009, so we're just looking at 2009. Assuming that these reductions are going to only persist 1 year, that would offset between 3 and 5% of the original cost of the expansions. And of course, if you think that they're going to persist longer, I personally think it's likely that they will, but I don't have the data, so being conservative. But if you think they're going to persist longer, then of course it would be higher by however long you think they're going to last. Okay. So then this, getting back to the question I was just asked, we break off these costs into costs for publicly insured visits, privately insured visits, self-pay, so it's out of pocket, and uncompensated care for the hospital. And we actually see a lot of, for hospitalizations, a lot of reduction in the publicly insured visit costs. Right? Put differently, those born right after the threshold have lower costs, spend less on using publicly insured money. We find a little bit going on for uncompensated care in terms of just seeing a lot of negative point estimates, but we don't find any statistically significant reductions. And then for emergency department visits, kind of interesting, we find a little bit more action on the self-pay visits as well as the privately insured visits. So it seems like there were potentially multiple payers that in terms of incidence, benefited from this policy. Okay. If we do a sort of a back-of-the-envelope calculation with this, it represents a cost reduction for the public payers of about 17.5 million and for private payers of about 3 million. And the rest is sort of in the residual. Okay. So that's sort of the main study that I wanted to talk to you about. Are there any questions before I wrap up? Yeah.
Is there any correlation between the sample of states that have your data and Medicaid managed care? Because Medicaid managed care can impose, NCOs can impose stipulations on when you can use hospitals or not, which would affect your visits. And because of data reporting, could potentially be a correlation between those states that collect your data, and also reporting that information.
So there could be. One thing I would keep in mind is that so the actual period when they experienced this higher coverage was in the 90s. So it was kind of before the tremendous amount of managed care penetration that we say now. So they just remember they had, they got the coverage in 1990, and they had it from 90 to 95, and now we're looking 90 to 99, and now we're looking in 2009. Their period of coverage differential is over, and in fact, we've looked specifically to see, and we thought it would be interesting to see if, now as young adults, they're no longer differentially eligible for Medicaid. But maybe they're more likely to be on Medicaid just because maybe they know the Medicaid system, they had it when they were a kid, or they know the, they know how to fill out the paperwork, whatever. And we actually didn't find any different effect, right? So it doesn't, no kind of contemporaneous Medicaid policies are likely to be driving these results. Yes?
In terms of the mechanisms, I think some of those stories about why childhood coverage would result in these effects one could think of a lot of sort of interesting pathways. One I was wondering about is whether people who get Medicaid as kids, is it possible that those families then, that's sort of a gateway to sort of discovering other kinds of programs, sign up for cash assistance because now they have the information about it, and that there's all kinds of income effects going on as well.
Mm-hmm. No, I think that's a really good point. I mean, I think even without the gateway mechanisms, could definitely be big income effects of Medicaid if you were paying out of pocket, for example, for your kids' care before. We haven't looked explicitly at enrollment like in the childhood period and other types of care, other types of social programs. But I think there is some research on that finds like you're more likely to enroll in like WIC, for example, if you have Medicaid. So I wouldn't be surprised if that was the mechanism. I'm not super optimistic that we would be able to like disentangle that in this particular empirical setting, but I think it's definitely a good area of research. Yeah.
Do you have data on education, and can you look at that or not?
Well, we don't have data on education in the hospital data. There is data on education. So other researchers have looked at like educational attainment related to childhood Medicaid coverage using the American Community Survey. They didn't use this research design. They looked kind of a difference in difference type of approach, and they found kids that had Medicaid coverage in childhood were more likely to graduate high school. So I think that that's a potential area for further research would be really interesting. It's certainly, I mean, the work I've seen certainly is suggestive that there would be such education effects.
Could the effect be actually through education? Not just the education is a separate thing, but also through education.
So like you get more education, maybe you learn more about the health system and I think that's plausible. Yeah, we don't have that in the hospital data. That would be really interesting to look at, like heterogeneous effects, especially since we know so much about peer effects and things like that in determining healthy behaviors. But yeah, I think that's really would be a really interesting direction for future research to see. Is this from education? Is this from income effects? Is this from just a very mechanical, like I needed this drug and I got it, or if there's other things going on? Yeah.
This is still ongoing, right? Like this type of data is still being tracked.
Yes.
I mean, do you guys expect that, like for diabetes, a lot of the hospitalization that you have is like maybe a pass out, have a coma, and that's way different than later in life problems, which is usually like amputation. So do you guys expect that like per year cost estimates are going to go up?
I expect that, yeah. And I mean, I think that is part of the reason we didn't see an effect when we looked kind of at the very short-term effects, because when you're 15, like you're pretty robust, and when you're 25, you're also really quite robust. And then when you're like 35, I don't know. I think there's definitely when you're 35, that's the end. I mean, you're a mess by then. And then no, but I think that it's very interesting, and we are hoping to do some follow-up work now. These cohorts are like exactly my age, so like this final study I'm going to be doing like in the nursing home, because like they won't be 65 until I'm 65, but at least some more it would be nice to get a good sense of like in their prime age years, like what does it look like? Yeah, what does the health profile look like? Great. Okay, so just to conclude, I think this is a very interesting area of research, obviously, and I think that it sort of has a broader message than just the benefits of Medicaid, which is that if we had just looked at the very short-term effects, we would have a very different conclusion than we have now by looking at sort of effects over the life cycle. And so I think that indicates that potentially there's a lot of promise in a lot of evaluation of social programs or public policies to try to take a little bit of a broader look and to think about what might happen not just today if we implement a policy, but in 5 years, and 10 years, and 20 years. I think there's a lot of research in economics and in public policy that's going that way, and I think it's just a very positive development for the discipline. So thank you so much for the opportunity to talk to you and to present my work to you, and I'm happy to take additional questions if there are any.